I'm Mark Markowski, a medical oncologist at Johns Hopkins University in Baltimore, Maryland, in the United States. Here at Johns Hopkins, we have been developing a treatment paradigm called bipolar androgen therapy, or BAT, for use in men with metastatic castration-resistant prostate cancer for several years now. We take men who are on ADT, who have low testosterone levels, and we administer intramuscular depots of testosterone. Now, they're maintained on their LHRH agonist or antagonist at the time. And when they get the IM depot of testosterone, their testosterone levels in their serum increases to supraphysiological levels and then decreases over a 28-day period. And what we end up getting is a rapid cycling of testosterone levels in the blood, which can then have a profound impact on the treatment of castration-resistant prostate cancer. In this study, since we've done so many clinical trials and have treated hundreds of patients, we wanted to identify a subpopulation of men who have had profound responses to BAT. And we identified 22 patients out of 114 patients that had a PSA decrease of 70% or greater. And we investigated which of those patients had molecular sequencing. And we found that the vast majority of these patients had a mutation in a homologous recombination DNA repair mutation and or TP53. And we found that was an interesting correlation that definitely justified further investigation. So TP53 mutations are fairly common. I mean, they can be found upwards of 20, 40, 50% of patients, depending on the study that you look at. So they are fairly common, and they do confer a more aggressive disease. So designing or tailoring therapy to these patients is really an unmet clinical need. I think, I kind of would take them separately. And I think if you have a patient that has an HRD mutation, there are FDA-approved or life-prolonging therapies available to them and PARP inhibitors, and those should be used across the board as standard of care. With P53, those patients may have shorter responses to standard hormone-based therapies, but may benefit from chemotherapies. So there are treatment options available for those patients that probably should be exhausted first. Bipolar androgen therapy is an experimental therapy. It's typically done on clinical trials. But I think what this study suggests is that that may be a suitable treatment for these patients if we get further study confirming what we found in this study here. I think that's an excellent question and remains to be determined. However, we have found very nice activity of bipolar androgen therapy after at least one novel AR targeted therapy, particularly after abiraterone or enzalutamide. And we find that BAT has been pretty successful at inducing clinical responses in that setting. I think the other benefit of using it after a novel AR targeted therapy, what we found is that whether you benefit or not from BAT, whether your PSA goes down or just continues to rise, there's a secondary benefit of BAT in that you can re-challenge patients with a prior novel AR targeted therapy. So if you have a patient who progressed on abiraterone, went on BAT, we've had success re-challenging that patient with abiraterone and have seen PSA responses and objective responses doing it that way. So that's the added benefit. I think it remains to be determined. We are doing additional studies looking at that. But if I had to answer, I would say at least after one AR targeted therapy. Certainly we've had success after chemotherapy. So that may be something we do kind of later on in the treatment course. I think it just requires further study.